Good afternoon, everyone. And now that you are welcome to the session of the new perspective in CTO PCI. Today, we are talking about the specific of the CTO PCI, and I'm moderator, Dr. Yamane. And today, we like to have a distinguished panel for the CTO arena, Dr. Masayekhi from Germany and Dr. Knaapen from the Holland. Today, we talk about some recent advances for the CTO PCI. So I'd like to talk about some specific history of the CTO technique as well as developmental history. As you know, over these 20 to 15 years, we have been struggling for the CTO PCI, but at the same time, we can achieve the great number of success. Among them, some of the technical aspect of the development we have achieved to close to or more than 90% of the procedure success rate and less than 3 or 2% of the major mortality as well as complication rate. At the same time, we shouldn't forget about some technical as well as a technological development, such as the guide wires and microcatheters. And today we have enough time to go into the detail. And the first presentation by the Paul Knaapen, who is one of the best pioneers of the CTO PCIs in Europe as well as whole world. Today he's talking about the guide wire and likely to talk. And today's session objective will be that if you want to have some skill set as well as an understanding of the CTO PCI, probably this is the best session to come. Thank you very much, Paul.
Thank you, Dr. Yamane, for this kind introduction. So I'd like to talk about the new perspective in guide wire selection, but also some of the characteristics of the old guide wire selection. I have nothing to disclose pertaining to the contents of this talk. By way of background, I'd like to tell you that we all know that CTOs are pretty common. We find them in 1 in 5 patients with obstructive coronary disease. Yet wiring has been traditionally with low success rate of about 60% with antegrade wiring, even in selected populations. So in general, we offer these patients less frequent percutaneous interventions and more frequent bypass surgery. However, as Dr. Yamane has alluded to, the advances in wire technology and in the retrograde wire access have now tremendously increased the success rate. So I'd like to talk about the advances in the wire technology. So not all CTOs are equal. On the left-hand side, you see a CTO which is quite simple with a microchannel. CT shows soft plaque with a microchannel. On the right-hand side, we see a heavily calcified long CTO. And you can imagine that the left-hand side CTO needs a different wire to tackle than the right-hand CTO. So not all CTOs are equal, and different wire for different purposes are very important. And we notice also from the JCTO score, if your JCTO score is very low, the chances of antegrade wiring with soft polymer jacketed wires are extremely high. However, when your JCTO score goes up, success rate of wiring goes down, and you need different types of wires with different levels of JCTO scores and also different strategies. So which wire to choose? Well, not so long ago, we have a myriad of wires from multiple vendors, and it was really undistinguishable which wire to choose, which we generally have this scheme which between the tip load and the support. And luckily, over the last couple of years, this has been tremendously simplified, predominantly due to the introduction of the ASAHI YE family over the last decade or so. And now we are generally distinguish the start of the CTO procedure with soft polymer jacketed wires like the Fielder XTA and the Fielder XTR. And if that doesn't work, you go to an intermediate type of wires, predominantly with the Gaia family, and now with the new iteration of the Gaia Next family, which is available in Japan, but not yet in other parts of the world. Also still around is the Ultimate Bros 3. And then a new introduction is the stiff polymer jacketed wires. A pilot-like wire is the Gladius. I'll tell you about that a little bit later. And if that doesn't work, you have stiff penetrative wires like the Confianza Pro 12 family. So basically 3 types of sorts of wires which can tackle most of the CTOs, and your toolbox now only have to encompass these. So again, I'd like to talk a little bit about the Gladius. This is what Professor Lombardi alludes to, a Pilot 200 on steroids. It's a stiff polymer jacketed wire like the Pilot 200, but now incorporated with Acton technology, which allows better steerability. It tracks long segments of CTO body with relatively low risk of perforation, but on the other end, high risk of subintimal tracking. You can also use this wire to get out of the subintimal track by performing a last technique by limited antegrade subintimal tracking, or very conveniently also by delivering a stingray balloon and then doing the stick and swap procedure with the stiff polymer wire, or even use it to re-enter with types of devices like the double lumen. It also forms a good knuckle if you want to perform any type of dissection or a star technique. And even so, it is, in my book, when all hope is lost. At the end of the procedure, when antegrade has failed and retrograde has failed, start over from the beginning with a Gladius wire, and you might even be able to obtain success. And even if that doesn't work, it's part of the investment. Also, a new, more stiff penetrative wire, which is in my toolbox now, is the Estada. When the going gets tough, the tough get going. This is basically sort of a Confianza Pro 20 or 40, but much less steerable than the Confianza Pro 12. But it's very convenient for very tough lesions where Confianza Pro 12 fails. It's also very good to stick out of stingray balloons in very calcified segments to get re-entry, for example, in the post-bypass patients. But it obviously must be used with caution because this wire will go anywhere. So, which wire to choose? This is a very simplified scheme by Dr. Brilakis. You basically start a procedure with a soft polymer jacketed wire, like a Fielder XTA or a Fielder XTR. If that fails and you know the course of the artery, either by angio or by CT, for example, you go to stiff penetrative wires like the Gaia family or Confianza Pro 12. But if you don't know the course of the artery, you don't want to perforate, you'll take a stiff polymer jacketed wire. This is traditionally the Pilot 200, but now more and more in my practice, it's the Gladius wire. So it all starts basically with soft polymer jacketed wires. These navigate you through loose tissue tracking or can pick up microchannels within the Fielder family. And this is basically such an example. It all starts with double arterial access. We have a clear cap, a short segment, a clear landing zone, and no real retro options. You start with a microcatheter, which is mandatory in each procedure, as Kambis will tell you. Take a soft polymer jacketed wire, in this case a Fielder XTA, and just navigate yourself through the body of the CTO. A very simple CTO, but it needs to adhere to the rules of basic CTO procedures. But also, when it gets more difficult, antegrade wiring starts with soft polymer jacketed wire. This is a JCTO score of 3. It's very calcified, as you can see, with the double arterial access. So trying this just with a soft polymer jacketed wire can just easily gain you success. And this is the first 2-0 floor of a Fielder XTA that passes. So even if you think this lesion is going to be very tough, it may be worthwhile just to probe it with soft polymer jacketed wire for 1 or 2 minutes. It will frequently bring you still success, even if you think you need a variety of dissection reentry techniques or the retrograde approach. Also, polymer jacketed wires are extremely safe. This is a slide of James Pratt. If you don't know the course of the artery, if the artery is long, if the artery is calcified, if you take a stiff wire, the likelihood of perforating are extremely high. If you take polymer jacketed wires, either being soft, but also being stiff, the chances of perforating are extremely low. So for patient safety benefit, polymer jacketed wires are much safer than stiffer wires. When is a lesion too long to start with soft polymer jacketed wire? The answer is never. This is a patient with a CTO of the RCA with good collaterals. You might want to go retrograde first, especially because the lesion length is 10 centimeters. But now by simply probing with a soft polymer jacketed wire just for 1 minute, and this is the first straw fluo, you can get through. The chances of this being successful are less than 10%. But the time invested in such a procedure is just a few minutes and 1 wire. So in a lot of cases, it's still worthwhile if you have a good antegrade cap to try this procedure. So the algorithm that we're used to analyze, whether that be in the hybrid or any other the algorithm, it tells you that if a lesion length is more than 20 centimeters, you should adopt to dissection reentry techniques. I think with the evolution of wires nowadays, this is an old scheme. This must be abandoned. Lesion length is, in my opinion, no longer a reason to abandon wire escalation, whether it's antegrade or retrograde. Once you end up in the subintimal space, then convert to dissection reentry, but not on forehand in most cases. So if the soft polymer jacketed wires fail and you know the course of the artery, you go to the Gaia family, which has revolutionized the PCI CTO and wire technology. And again, nowadays, the Gaia Next family. These are very directable wires, very easy to navigate you through the CTO body and to stay intraplaque for as long as you can. So this is an example of a PCI CTO of the circumflex, where we started in an antegrade fashion. You see the microcatheter, you see the soft polymer jacketed wire, and the soft polymer jacketed wire ends up in the subintimal space within seconds. You bring up the microcatheter, you exchange the soft polymer jacketed wire for a Gaia wire, and you can see it that it re-enters from the subintimal space into the true lumen with that pop. You see that direct pop. Then you're in the true lumen. So this is basically wire escalation from soft polymer to stiff intermediate type of wire, in this case the Gaia second. Another example of such a case is this patient with a CTO of the RCA. Again, I would like to tell you that soft polymer jacketed wires are the way to go first. This is a soft polymer jacketed wire, fielder XTA. We end up in the subintimal space. We switch to a Gaia wire, and now look how differently the Gaia wire behaves as opposed to the soft polymer jacketed wire. It navigates towards a tiny early PD branch, which we're now into. This way, you have already conquered half of the CTO. You bring the microcatheter there. You exchange for a workhorse wire. You bring down a double lumen catheter, in this case a Sasuke, to get yourself back into the body of the CTO. And now start again with soft polymer jacketed wire, in this case a fielder XTR, to navigate you through the further. So it's up escalation, down escalation, use of multiple wires and multiple MCs, which Kambis will tell you a little bit more about in the next talk. And to finish the case. So having knowledge of these wires is extremely important. And you don't need to know that many wires, just about 6 or 8 or 10, and you have your toolbox complete. Also, we must not forget that there are alternatives to wire technology alone. And this is predominantly with reentry devices, in this case, the Stingray balloon. This is a case where the soft polymer jacketed wire ended up in the subintimal space, and instead doing techniques like parallel wiring, etc., we popped in a Stingray balloon. Stingray is in the subintimal space, and now you take a stiff wire like a Confianza Pro 12, or if that fails, an Astado wire to get yourself a reentry. In this case, it's called a stick and drive maneuver. You stick out of the side port, you drive it into the artery, and even with Astado 20 or 40, this can be done safely and in an efficient manner. So not only staying stick to wire technology alone, never forget about the other tools that we have, double lumen catheters, triple lumen catheters, Stingray balloons, to help you get success. This is also that sometimes we don't need always wires. There's, for example, in-stent occlusion. We can use blunt dissection devices like the crossbars, which has been popularized in the United States and in the UK, or are disseminating now throughout the world. In this case, you can see that the crossbars pops through the in-stent occlusion, which tends to stay within the struts, easily navigating you to stay within the true lumen. So not always wires are needed to solve a case. And in this case, a crossbars is good for in-stent occlusion. This is not only in the hybrid algorithm, we now also see disseminated in the Asian Pacific algorithm. This is a slide of Dr. Tsuchikane, and now being adopted that the crossbars is now indicated for in-stent occlusion, but also the Stingray balloon is now entering the field in Asia to get re-entry. I think all these algorithms nowadays tend to become more similar, and there's a new paper coming out by Dr. Brilakis in JAC soon about the fusion of all the worldwide schemes to come to a more consensus about how we should approach these CTOs. This is very successful. This is the research database led by Jo Dens from Belgium in 1,214 patients, showing success rate of almost 90%, with 75% of these cases being wire cases. So wiring has become extremely successful. And this is not only so in the low JCTO scores, but still holds true in the higher JCTO scores. With advancement of wire technology, success rate in even more difficult cases tends to go up. However, this is all antegrade work, but we also have the retrograde approach if antegrade fails or we have no cap to start with. And retrograde wiring can be relatively more easy because the distal part of the cap tends to be more soft. We can use bypass grafts, septals, and epicardials to navigate ourselves way through. And actually, you only need 4 wires if you start a retrograde the program in your toolkits. This is basically an ASAHI Symposium wire as a workhorse to get retro. If that fails, you can go to polymer jacketed wires like a Xenon Black, or if you have highly tortuosity and you want to navigate through a Fielder XTR. But I think one wire we should not forget, and it's been relatively novel, not for Japan, but for the rest of Europe, is the SUO 03, which has really revolutionized the way you can pass tortuosity through very difficult segments. Not only septals, but specifically the epicardials. This is a caravel into a right ventricle branch with high tortuosity, which feeds the LAD. And now you can see how easy it is for an even incompetent operators just to navigate a SUO through. And the biggest advantage of the SUO is that the SUO tends to break more easily than the epicardial does. So chances of perforating with SUO are extremely small as opposed to more stiff wires like the Fielder XT are. So even crossing epicardials nowadays can be more safe also in less experienced hands. So I'll show you a case where antegrade wiring failed and successful retrograde wiring was an option. This is a case where we have good septals on a CTO of the right coronary artery. We started antegrade with soft polymer jacketed wire, ended up in the subintimal space, and instead of doing all sorts of difficult maneuvers, this is a Xenon wire just to get ourselves through those septals, which is very easy. It's not magic. Anybody can do it. We advanced the microcatheter, and now that same soft polymer jacketed wire, the Fielder XTA, navigates from the true lumen to the true lumen and enters the guide so you can externalize and finish the case. An example of where antegrade wiring may end up in the subintimal space and retrograde wiring from true to true is more easy. Also, when you have proximal gap ambiguity and you don't know where to start, obviously starting with soft polymer jacketed wires is not an option if you don't even have a clear cap. So some cases are still dealt with in a primary retrograde approach. These have good septals. Again, you need the good tips and tricks and the clear tools. This is a 150 Corsair Pro. You do a tip injection. You see the course of the artery. This is a simple Xenon wire, which will get you through that septal up into the LAD. And now you have solved the proximal gap ambiguity by going retro. You end up to the proximal cap. And I want you to know that retrograde wiring is exactly the same as antegrade wiring. Soft polymer jacketed wire, stiff type of wires if you know where you're going, penetrative wires. And in this case, we needed a Confianza Pro 12 to get through this cap. Make sure with IVUS that we entered into the left main prior to the exit of the circumflex and deal with this case. But again, retrograde wiring escalation is exactly the same as antegrade wire escalation once you're there at the distal cap. So these retro cases, they can be quite difficult. This is a patient with an ipsicollateral. We frequently use to get retro tip injections to see where the artery is going. In this case, tip injection really helps. Either one of the 4 wires, in this case, this is a SUO, will get you through that tortuous epi. Small microcatheter like a caravel, which Kambis will allude to, will get you through. And then wire escalation starts again. And again, soft polymer jacketed wire failed. Gaia failed in this case, and we needed a Confianza Pro 12 to puncture that cap and get reentry, as we can see right here. This is Confianza Pro 12. going into the left main, exchanging for a workhorse wire to navigate ourselves through that left main, check with IFIS where we had re-entry, and finish the case. So dependent on your skill set, you can elaborate on more difficult cases, but wire technology is key to help you achieve that purpose. So in conclusion, I'd like to state that antegrade wire escalation is and will be the mainstay of PCI CCTO. It's 50% in third-tier luminary centers, but it's going up to 60 to 70% due to wire technology. Success rate has gone up tremendously, and wire choices have been extremely simplified. But please be aware of the updates. There are multiple vendors these days introducing wires, and updates also within the ASAHI families are there. Most recent examples like the Gladius, the Suo, and the Astato should be kept in mind to deal with your cases. Retrograde wire escalation is easy and can be more successful than antegrade wiring. And please be familiar with alternative techniques when wiring failed, such as dissection reentry techniques, and have those tools like the Stingray balloon on your shelf to save you from these cases. Thank you, and I'd like to give the word back to Dr. Yamane.
Paul, thank you very much for an excellent talk. With regarding your technique, how do you fill the gap between your estimate before the procedure and what you have done in terms of the guide wiring? Because even if you read the CT scan before the procedure, sometimes physical characteristics of the CTO is quite different before you touch on the guide wire. So how could you feedback your experience and your plan into the
that's a very important question, and I think it's not to get stuck in failure mode. I think that's the summary of what I'd like to say. So if you have a plan, fine, but if the plan fails, switch quick. So Elliot Smith always says, fail fast and switch quick. You know that you have all these different wires, different techniques, different strategies. So don't invest too much time in something that's about to fail and then switch, because you'd like to escalate through all the possibilities of tackling a CTO, both in wire technology, microcatheter technology, and strategies within 90 minutes or so. CTO should on average not take more than 90 minutes. It's rare in our lab. So don't get stuck in failure mode. It's a very good message. Thank you, Dr. Yamane.
Okay, thank you very much. It's first rate and the superb advice for everybody involved in the CTO. Thank you very much, Paul. Now I'd like to introduce the Kambis Mashayekhi, who is most voluminous and the talented CTO operators in the world, and probably he will teach us from the super duper technique as well as the very much basic techniques for exploring how to manage the CTO with a microcatheter. Kambis, please.
Thanks a lot, Masahisa. So, well, I will talk about the contemporary microcatheter toolbox, and I will concentrate especially on the ASAHI toolbox of microcatheters and not on dual lumen microcatheters. So the focus today, those are my conflict of interests. So the focus today will be on the Corsair, Pro XS, and the Caravelle. And Actually, in 2010, the implementation of the reverse card was extended, right, by the Corsair, and I think this was a big revolution. And also, this paper was published in Czech Intervention in February 2010, and it really could increase success rate in complex CTO PCI. Well, in Europe, finally, in 2011, the Corsair was launched. This microcatheter gave us really a good opportunity for retrograde options. And then in 2016, Caravelle came up, helped us a lot, like Paul Knaapen already explained, especially in tiny epicardial connections, but also very tiny tortuous septal connections. And then the next evolution came, which was the Corsair Pro in 2017, with a better torqueability, a more flexible tip actually, and a more resistant tip for getting more into calcified lesions. And last but not least, in last year, the Corsair Pro XS was launched. Now we'll focus a little bit also on this microcatheter. So when you think about the standard microcatheter, which is the Corsair Pro, you actually can use it for complex PCI, so in very tight calcified lesions, whenever you need really big support, actually. But it's also an excellent device for antegrade CTO body crossing, and also for retrograde CTO collateral tracking, especially when you have a septal collateral connection and you need support for your retrograde wire for having more fibrotic, calcifibrotic tissue to penetrate, also from retrograde. Well, the Caravelle is a completely different design microcatheter. For sure, if they are not so calcified lesions, you can use the Caravelle very nicely also for complex PCI, actually, as a very elegant microcatheter. But we don't use it too much in really uncrossable antegrade calcified lesions, because the tip is a little bit more flexible than in the Corsair, and therefore it can also be attached when you over-rotate the device. This has to be acknowledged. So for the antegrade CTO and body crossing, it's still, when you have not calcified lesions, it's still a very good possibility. But the really impact of the Caravelle is the collateral channel tracking, especially the tortuous epicardial crossing. So when you take everything together, you have here the Corsair Pro, which have a good crossability, support, and talkability, and you have the Caravelle with the benefit of low profile and trackability and guidewire maneuverability. So taken together now, the hybrid of those different, let's say, advantages with torqueability, low profile, and trackability has the Corsair Pro XS. Well, it's, let's say, a hybrid between the Corsair Pro and the Caravelle. And the good thing about it is that with its low profile, you can track even smaller channels, but you have still the opportunity to torque this device, right? So like the Corsair. So which means that once you think about the microcatheter positioning for complex PCI and main characteristics which are required are low profile and trackability, I think the Caravelle and the Corsair Pro are very good devices. The Corsair Pro especially when you need higher support and torquability. Regarding the microcatheter positioning of the when you need something for the CTO crossing with crossability, talkability, and support, I think the Corsair Pro is a very good microcatheter. But if you need a lower profile device, then the Corsair Pro XS is a very good alternative device. So regarding the anatomy that you have once you cross CTOs, you often are going retrograde via septal channels, right? And the septal channels can have different diameters, and they are from 0 to 3 French, CC 0 to 1 to going up to CC2, and can be even very large, right? So you should use a device where you can really torque it and also has a good trackability. And this can be done by the Corsair Pro when the septals are not very small and not too tortuous, but if they're really tiny and tortuous septals, you have actually to use the Corsair Pro XS, which is the better device for this kind of circumstances. Regarding the epicardial tracking, here you need a different subset of device, right? So here you also need a low profile microcatheter with a good trackability. And this actually can be the Corsair Pro X. And if it's even more tiny channels, the Caravelle would be the choice. So this is my personal preference of different microcatheters at the moment for septal crossing and epicardial crossing. And for the septals, I really like to have a rotatable, torqueable microcatheter. And from the ASAHI group, I really prefer the Corsair and Corsair Pro X for the septals. For the epicardials, actually, once they're really big epicardials, the Corsair Pro X is an excellent device for that. from ASAHI and CC1 collaterals, you can use the Carvel. For sure, there are also different other devices from Teleflex, from Boston, so which can be also used, and many companies, also Terumo, but focusing on the ASAHI products, I can tell you that those have a really good devices for this kind of scenarios. So let's think about the septal crossing here. Well, the septal crossing with the Corsair, and I will show you an example. Here you see a septal crossing with a channel dilator, and what you can see is the rotational force, and then I wait with the to give the pressure actually towards the the device. Can you see? So it's a rotation, and then I give push, and what happens is the microcatheter is going continuously over this tortuous span where there's a lot of resistance there. So it's a rotation, counterclockwise and clockwise rotation, and then I give a little bit push on the wire, and I wait till the microcatheter goes forward. So here you see a little bit a different scenario. It's a not so complex passage from the septal. It's here a cyan blue wire. The cyan blue wire actually just is navigated forward with a septal surfing, we call it. So we just analyze the septal construction and feel if there is any resistance. I can remember that even I think Paul was one of the commentators during this case, and then the wire just went through it. So if it's so easy to pass the wire, almost the passage of the microcatheter is also easy. So you can use a really good microcatheter with good backup for the wire. This is the Corsair. You see that Colm Hanetri is holding the guide a little bit because the backup of the left radial was a bit less. And I fixed the microcatheter with my two hands. The one is rotating and the other is pushing the device. So if you don't feel any resistance, you can even rotate the microcatheter relatively in a fast manner. But if you feel resistance, just make slow movements with the microcatheter tip and try to give a little bit more transition force from the microcatheter towards the tip. So take your time not to over-rotate the microcatheter, because this is actually what can happen. If the tip is fixed, even in the septal, and you start to over-rotate, sometimes in bending, the microcatheter can even rupture, right? This was a rupture into the right ventricle. It was not a problem, for the patient actually, but it should not happen actually in epicardial connections, right? So do not over-rotate this. Then go back with a smaller device, with a more tinier device, with a device like the Corsair Pro XS or even the Carvel. And another thing is where you should not over-rotate the devices is once you get stuck in calcium, right? This was a case, a very calcified RCA, but here you can see the wire, the confiancer 12 was not able to penetrate. I want to rotate the microcatheter towards the confiancer tip. What happened was that you can see what happened. The tip in the calcium was getting fixed and then trapped with the wire, so I had to bring everything out. And this can happen when you over-rotate in calcium the tip. So I didn't have Corsair tip loses, based on that. But what I had actually was that the wire is really, you cannot detach the wire from the microcatheter when you over-rotate. So therefore, once you come in the situation where you feel a lot of resistance, always check if the wire is still free and you have not a higher resistance on the wire, because this gives you the indication that probably the tip is going to be destroyed and damaged. Well, coming now to the other part, which is more the tinier septal crossing part, and I will show you where I use a device, the Corsair Pro X, in a scenario over a last remaining lemur, and I show you why I use this microcatheter as well. So this is the Corsair Pro X with a new Kinka shaft, which means that you have a 2.1 French distally, and then you have also 14 braidings, and so it's very good rotatable towards the tip and even tiny, right? So you have 2.1 French of the distal shaft and a strong backup from the proximal shaft with 2.9 French. So, well, you can use this device in 6, 8, or 7 French, depends on what you need additionally, but it's possible to take let's say trap it out in 6 French as well. So here we have a complex CTO with a Crosshair Pro X. It's going over left mammary, so very long way for the device. Here you see some spasm as well, but you don't want to have too much ischemic events. And here you see how the Crosshair Pro XS can just pass the collateral, but here you do have less support from the lemur because we were on left brachial. So it takes the time, right? You need to give the device the time, but with pushability alone, with the carvel, it might end up that you might lose the position of the guide, which has very low backup force here. So therefore, you need a device which has also a backup which you can rotate. And here you can see it's possible to go over this whole lemur, over the septal, over the RCA, and finally end up for an externalization and final stenting. So this is possible over this really long, a very complex scenario, and still it was a very calcified CTO. So you have all of these characteristics you would need, which means trackability, torqueability, and still enough backup for the wire to make these reverse carded calcified scenarios. So coming now to the, let's say, epicardial scenarios here, and the epicardial, especially the small ones, there the carvel is the microcatheter of choice, as Paul Knaapen already also showed us. So, you know, with this kind of connections, which in the past were probably a little bit more problematic, now the 003 technology is the excellent wire to go. It's a very safe wire, as Paul Knaapen also showed us, and you can see with the carvel, you just go through it without any resistance. So it's a very, very safe opportunity to have a retrograde wire on place. So for sure, we can use these devices, this combination also for more complex scenarios, especially if I might focus again on also the Sur-Serif, because I think it's a great combination and we all agree here. I think that Sur-Serif with the carvel is a great option for epicardial collaterals. And here you can see what the Sur-Serif is possible to do nowadays. It's excellent example. And the carvel can just follow here without any big problem. And this is a very tiny collateral connection in a patient with a severe renal failure. So we try to use a less contrast, if possible, with super selective injection. And also here, the combination works very well, and the carvel can track this channel without damaging the channel. And this is very important. So let's say finalizing those three devices. I think when you need a microcatheter with a lot of support, actually wire support, because you have a very calcified long CTO actually, and you have a good channel, you need a microcatheter which has a great pushability, a great crossability, and with a good torque response towards the tip. This would be the Crosshair Pro. If you have very tiny channel, and you have problems with the trackability and there are torches, you can just, and you have a good backup from your retrograde gear, the carvel, and especially on the epicardials, would be the microcatheter of choice, because you have a great flexibility, trackability, and you have a very nice integrating. The wire response is very good in this device. So I think for more complex scenarios and still smaller channels, so more complex CTO lesions where you still need a little bit wire support, and also you need a more possible for trackability, and you have less backup support from the guide. I think the Crosshair Pro X is a good alternative and a good let's say hybrid device of both of it. And the big advantage is that you can also torque it. It's a very good torqueable microcatheter. So I hope that I could give you a little bit explanation of all of these devices, and a little bit also my personal view of those devices. And I think we still have some minutes which are open for discussion. Thank you very much.
Thank you very much, Kambis. Probably this is a reminder that if you ask the difference how to control the carvel and Corsair XS, probably which is the most important part of the technical point.
Yeah, that's thank you so much, Masahisa. It's very important actually. what you should understand is that the caravel itself has a very, very good torque response. So which means that once you rotate the caravel 360 towards the tip will do the same, right? It will go directly with your response, which means, one, the caravel is fixed in calcium or somber, and you torque, so the transmission between the tip and the shaft has a huge stress, right, regarding your power on rotation. So this might lead to a detachment of the tip. So the user should understand that you should not rotate this device once you have calcified lesions. It behaves a little bit different in epicardials, right? So when you have really epicardials and you have a lot of tutorcity, and the only push is not available because you are probably on the radiopaque part of the suocerebral, you might use a little rotation, but only 180 degree or maximum 270, not too much, and rotate also counterclockwise again. So you might have a little bit better trackability. This is the big difference between the Corsair Pro XS. The Corsair Pro XS can be rotated in a nice manner as we know it from the Corsair, and which means that you can rotate it several times, and the tip response, so the torque response towards the tip is not 1:1, it's probably 5:10:1, which means 5 to 10 rotation that the tip is rotating one time. And this explains you why you actually can also use this device a little bit better in, let's say, where you have a little bit more fibrotic issue.
Okay, thank you very much. Paul, do you have some comment? Because you have also extensive experience with microcatheter.
Yeah, so I basically want to give my compliments to Kambis for this great overview, and also highlighting the fact that you have 3 types of microcatheter. You have the default ones, the bulky ones, being in this case for the ASAHI family, the Corsair Pro. You have the sort of intermediate type, which is still braided, so are still torqueable, but slimmer in device, which is the Corsair XS. And now going from 2.7 French to 2.2 French. And then if that doesn't work and you need something very flimsy, very, very delicate, then you have the Caravel, which is the 1.4 French device. Basically, you only need 3 of these devices in your toolbox. And as Kambis also alluded to, we have multiple vendors from Teleflex and from Boston. And it doesn't really matter which microcatheter you use, but they fall into these 3 of the categories: the bulky ones, the intermediate type ones, and the very slim ones. And if you have one of each types on your toolbox, then you're good. In addition to these types of microcatheter, you need sort of plaque modification microcatheters, which in my lab is the Tornus, also from ASAHI. Or you could use a Turnpike Gold, for example, or Turnpike Spiral from the Teleflex company. So in addition to these microcatheters, a plaque modifying the catheter like a Tornus is very handy to have in the toolbox as well.
Thank you very much, Paul. As you alluded, that even the one microcatheter falls into some failure mode, probably it's better to switch to the other mode, is a hidden message, I guess. So thank you very much.
And I would also like to say that sometimes the logic doesn't really compute. I have had cases where the Corsair Pro didn't go, and then I took a Caravel, and the Caravel didn't go either, and then I took a Corsair Pro XS, and the Corsair Pro XS went. Whereas from an intellectual point of view, the Corsair Pro XS is more bulky than the Caravel, yet sometimes you cannot predict the physiology and the anatomy, and just try something else if something fails. Even if something is bigger, it might still pass where something smaller didn't.
Okay, thank you very much. It's a superb, excellent advice from the specialist. So it's time to summarize. Thank you very much for the excellent talk regarding the CTO guide wiring as well as microcatheter usage. Probably one of the summary of the slide would be, when you know the vessel course, probably you can step up the very stiff guide wires, such as a Gaia or the Confianza Pro, This is one of the example for the heavy calcified RC long CTO. But when you use the Gaia Next as well as integrate as well as a retrograde approach, probably you can use it in a very flexible manner, reaching the very good end of the procedure outcome. Whereas if you don't know the vessel course, probably you may start with a very soft polymer jacketed wire, such as the XTR, but then you may use, this is a Miracle Neo 3 gram, which is like Ultimate Bro 3 gram, and ending up with the retrograde outcome. But retrograde Gaia Next 2 actually rendezvous in the integrate carrier microcatheter. So in this case, we result in the superb outcome for the procedure as well. So outcome would be the probably a very important part, but the take-home message will be some technological development has eyewitness for our procedure, but like a channel dilator, the Corsair XS, we have advantage for using those specialty device. At the same time, we have eyewitness guide wire development, such as the Filter XTR to the Gaia Next. And surely we must be always a better way to solve the difficult problems, such as the original cart to the guide catheter extension reverse cart. That way we can have the bright future in our hand, and hopefully this will be of great help for everybody who aspire to be proficient in CTO PCI. Thank you very much for your attention.